صباح الخير. We will begin our session by Professor Salim Eid. I'm really honored to introduce Professor Salim Eid, one of the eminent speakers and expertise in GIT malignancy. Professor Salim Eid is a professor of medical oncology in NCI Cairo. He will discuss the topic of adjuvant treatment for colon cancer stage 2 and stage 3 as a standard of care.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for the introduction, and I'd like to thank Ain Shams University Committee for the kind invitation. Today we are talking about one of the standards in the GI malignancy and rapidly evolving field, which is the adjuvant treatment in early stage colorectal cancer. Here are my disclosures. And the agenda will include three topics: the introduction, adjuvant in stage 2, and adjuvant in stage 3. As you know, that in early stage colorectal cancer, surgical treatment is the main curative treatment. The standard of care in leukoregional disease, and its role is rapidly evolving in selected patients with metastatic disease. Not all the metastatic disease, but there is a certain group of metastatic disease who are candidate for surgical resection, but still the main treatment for the leukoregional stage of the disease. And despite this surgical management, still we have faced the problem of recurrence. The recurrence mainly depends on the initial stage of the disease at the time of the resection. So the main cause of the recurrent disease is the micrometastatic disease before resection. So adjuvant treatment was established to eradicate this residual or micrometastatic disease, and this may be consequently will improve the outcome of the disease and improve the survival. The rate of recurrence is mainly dependent on the initial stage of the disease at the time of the surgery. If you look here, this is the early stage of the disease based mainly on the T stage and M stage. For the first part, while we haven't any lymph node metastasis, we have T1 and T2, so we face stage 1. If we have no lymph node metastasis and we have T3 and T4, we face stage 2 of the disease. But if any positive lymph node in the resected sample, will face stage 3. So stage 1, 2, and 3. For stage 1, there is minimum percentage of recurrence, so no role of adjuvant treatment. On the other side, we have higher recurrence rate after stage 3 resection. In between, we have inadequate evidence or borderline evidence for adjuvant treatment for stage 2. So starting with the stage 2, the problem is adjuvant in stage 2 colon cancer is not routinely recommended because most of the patient will be cured by surgery alone, and only minority of the patient will have a relapse. Unfortunately, with the most of the adjuvant clinical trial, we have modest improvement in the survival, but the problem this trial lacking the large amount to find this mild benefit or modest benefit from adjuvant chemotherapy in this stage. The only trial which includes the whole population of stage 2, which showed any benefit for adjuvant treatment of chemotherapy is the QUASAR trial. However, they include all the patients, so there is modest benefit, but still some group of patients in stage 2 will benefit. How can we find this group of patients who will benefit from adjuvant chemotherapy and spare the rest of patients who will not benefit from adjuvant treatment? Here are the QUASAR group who included, the trial included most of patients with stage 2 and some patients with stage 3. When they analyzed the patient with stage 2, they found about absolute benefit, 3% absolute benefit of survival benefit in favor of adjuvant treatment. But who are this group of the patient who will benefit from this? Remember that we included in stage 2 T3 and T4, and T4 can be subclassified to T4A, T4B. If you look here, you will find that the survival of patient with T3 is better than T4. And if you look to T4 group, maybe the survival is lower than even stage 3. So maybe subclasses or subgroup of patient in stage 2 may have poorer outcome and may be candidate for adjuvant chemotherapy. Mainly, the higher risk group who may be candidate for adjuvant treatment, they looked for some risk group which are based on the morphology, I mean TNM staging, mainly the T4, obstruction, perforation, higher grade inadequate lymph node, lymphovascular invasion, perineural invasion, and the elevated preoperative CAA. Unfortunately, there is no consensus which group will benefit and which group will not benefit. The ASCO showed some risk factor, the ESMO showed, the Japanese showed, so no consensus how to use these morphological feature to define patient with high risk group. And maybe there is some risk factor beyond this morphology. So they went to more beyond the morphology to the molecular, like CDX2, which is immunohistochemistry marker related mainly to GI group, the MSI, the newly evolving circulating tumor DNA, the recurrent score, I mean oncotype DX colon, which may now oncotype DX used properly in the breast, but there is some data about it in the colon, stage 2 mainly. Sorry for this. So if you face one of the morphology or morphologic risk group, this patient are candidate for chemotherapy, and we will discuss some of the molecular factor which increase the risk of recurrence in stage 2. If we look to CDX2, CDX2 is one of the immunohistochemical marker in favor which diagnosed patient with GI malignancy. If you lose this CDX2 marker by immunohistochemistry in stage 2, those patients carry a poor prognosis. And those patients benefit more from chemotherapy. As you saw, the whole group of stage 2, no benefit from adding chemotherapy, but in CDX negative patients who will not receive chemotherapy, the outcome is poor, but if you give those patients chemotherapy, the outcome may be better. This is regarding CDX2. What about MSI, which is routinely done now in all patients with stage 2? MSI tumor, as you see here, in stage 2, about 20%, decreased by, when you go up for a stage, decreased to 12% in stage 3, and we face it in about 5% in stage 4. So it's carry a good prognosis, so only minority of patients who will progress to metastatic disease, so it reflects good prognosis of the patients. Patients with MSI high are characterized by early stage, mainly in the right side, higher tumor grade, lymphocytic infiltrate, and mucinous histology, and carry a good prognosis. Whatever you do, the test by PCR or the immunohistochemistry, there is good concordance between both. What the impact of MSI on the decision making in stage 2, as you see, for patients for stage 2 who underwent surgery alone, MSI high carry a good prognosis, while MSI low or MSS or proficient MMR carry a poor prognosis without adjuvant chemotherapy. If you give adjuvant chemotherapy for patients with MSS, the survival will reach to those patients with MSI high even without chemotherapy. So patients with MSI high, you can spare chemotherapy for this group of patients. The oncotype DX are used, but its practicality in colon cancer is not that in breast cancer, but it reflects, according to the risk, the outcome of the patient. We couldn't predict its impact on the decision of adjuvant chemotherapy, but I can reassure you that the score are matching with the clinical pathological factors, so no need, and we are not always use this oncotype DX in the colon in stage 2. What about the circulating tumor DNA, which is rapidly evolving in the field of oncology? So there is a lot of trials assessing this, starting from Taiji et al. In 2016. They found that For patients who have already positive circulating tumor DNA after surgery, the outcome is poor. But if you compare those patients, if we already based on morphology only, there is a difference between the red one on the right side, upper one, have the high risk morphological feature based on the clinical pathological feature, and the clinical low risk, this is based on the clinical features only or clinical pathological factors. But if you rely on the circulating tumor DNA positivity or negativity, you will find there is significant difference between both. If you added, sorry for this, and after chemotherapy, if you added chemotherapy, the benefit will be better for patients who are achieving negativity of circulating tumor cells if they are positive before. Also, if you give chemotherapy for patients with positive circulating tumor DNA, and if you achieve negativity, the outcome will improve. But patients who fail to achieve negativity after chemotherapy, you expect a poor outcome. You have to escalate your treatment. This is the first trial for circulating tumor DNA. There is another trial which try to see this data are reproducible or not, showing the same results. Positive post-operatively circulating tumor DNA carry a poor prognosis compared to negative. But if you give chemotherapy and still there is positive circulating tumor DNA, you will expect a poor outcome and poor survival of the patient. And also, the positivity of circulating tumor DNA may expect a tumor recurrence at least 1 year before you assess recurrent based on the radiology. So it is very sensitive marker to assess the recurrence of the disease. The third trial in this field also try to assess this feature and also, but more mature, and try to escalate the treatment based on this, and randomized patient to give treatment decision based on the morphology. This is the group 1, or the treatment are modified according to the presence of the circulating tumor DNA. So they found that if you decide treatment based on circulating tumor DNA, I mean, if you find circulating tumor DNA negative, you will not give chemotherapy. If you find it positive, you will give chemotherapy. They found that if you based on circulating tumor DNA, the use of chemotherapy decreased from 28% to 15%. So if we reduce this incidence, will this be affecting the survival? As you see, no difference. If you based and you declined chemotherapy from certain group of patients with circulating tumor DNA negative, you will find the same survival if you used it or based your decision on clinical pathological feature. And also, if you give chemotherapy for this high group of the patient, you will improve the survival and will decrease the recurrence from at least 50% to 10% for those patients. So very promising and very evolving field in the field of oncology. And I mean, there is a lot of factors which may affect our decision making in stage 2, and the field is still evolving. I'd like the protocol or the guidelines based on the ESMO, mainly more mature. Yes, it's based on the clinical pathological feature and MSI only, but they proper classify the patient in low risk, as you see, or intermediate risk. Intermediate risk, just some patients who have one of the risk factor. If those patients with one risk factor and have MSI high, you will not give chemotherapy. No risk factor, you will not give chemotherapy. If the patient with intermediate risk, I mean one of these risk factor and MSI low, you will give single agent chemotherapy. But if the patient have high risk of recurrence, you will give chemotherapy, and better for this scenario to give combination rather than single agents. So in stage 2, the routine adjuvant chemotherapy is not recommended. The proper selection of high risk group for recurrence may need adjuvant chemotherapy. We based now on morphology and immunohistochemical feature, and the MSI are now the main decision maker, but in the future we are waiting for the evolving role of circulating tumor DNA and also the immune score. So the risk stratification in stage 2 is a hot area of research and really evolving. No consensus which criteria we will use to assess how to select a group or high risk group of patients with stage 2 colon cancer. What about stage 3? We know that the standard of care in patient with stage 3 after resection is the doublet chemotherapy. Irinotecan no more used in combination, only oxaliplatin based. No benefit from targeted treatment in the adjuvant setting. Toxicity, but we use 6 months of treatment and we face the toxicity, mainly peripheral neuritis. This is based on the result of MOSAIC trial, which showed doublet with oxaliplatin-based chemotherapy is beneficial than monotherapy. And this is the result of MOSAIC, showed significant benefit in favor of doublet with oxaliplatin compared to single agents. But if we look, we give 6 months of chemotherapy, and we faced already, we have, based on the MOSAIC, there is survival benefit, but we faced always with the peripheral neuritis, diarrhea, we have higher cost. But if we limit it to 3 months of treatment, yes, we will show proper improvement and lower risk of the toxicity, and for sure the cost and the patient will be satisfied. But this will affect the outcome or not, we don't know. We learn from the subgroup of patients in the MOSAIC and other group in the adjuvant treatment that the recurrence mainly based on the lymph node, the number of lymph node, and the stage in between. This is within the stage 3. I mean T1, T2, T3 are completely different than T4, N1 completely different than N2. And if you look for stage 3, it is very heterogeneous group. As you see here, there is some group of patients with good outcome compared to other group with poor outcome. This is within the stage 3. Can we treat those patients with 6 months of adjuvant chemotherapy? I mean the same. We have to look in between according to the subclasses of patients. So if you look for the MOSAIC trial, which included also patients with stage 2, there is benefit for patients with stage 2 and stage 3. If we limited our analysis to only patients with stage 3, the benefit will be more. But if we focus with the higher risk group with stage 3C, I mean T4 and 2, the benefit will be more than stage 3A. So the higher the stage, the more benefit from doublet chemotherapy. So can we de-escalate the treatment for certain group of patients in stage 3? This is the question addressed by at least 6 randomized trial worldwide, try to ask 3 months of oxaliplatin-based doublet chemotherapy versus 6 months. As 3 months is non-inferior to 6 months, those 6, they reach different conclusion, but they conclude these all 6 trial in one analysis called the IDEA, ask the same question, 3 months versus 6 months in patient with stage 3. They based mainly non-inferiority trial, asking is this non-inferior to 6 months or not, and based on the result, as you see, if the line in this side, it will be non-inferior, here non-inferior, but if it touch the inferiority barrier or line, it will be inferior. As you see, the trial failed to show non-inferiority. I mean, still 6 months in the whole group of stage 3 is better than 3 months. But as we know, this very heterogeneous group with subclasses. Can we do further analysis to assess which group will benefit from 3 months versus 6 months? This is the subgroup analysis based on the T and N stage. They classified the patient mainly into 2 groups, the low risk group, mainly T1, T2, T3, and N1, or patient with high risk group which have any T4 or any N2. Those patients are classified according to this, according to the idea to have high risk group. And as you see here, no difference if you used oxaliplatin-based regimen between 3 and 6 months in patient with low risk group compared to the high risk group. Another analysis, sorry for this, another analysis based if you use Folfox or the K-Box or Zelox. If you use K-Box, the same, no difference between 3 or 6 months. If you use Folfox, you have to stick to 6 months of treatment. This is based on the regimen, but what about based on the risk, based on the stage? For the low-risk group, on the left side, 3 months is equal to 6 months. But in the higher risk, I mean T4 or N2, 3 months is inferior to 6 months. For sure, this trial reflected on, if you use 3 months, on lower incidence of peripheral neuritis and diarrhea, as you see for this, and for sure for the cost also. So it is very complicated analysis, but if you use Zelox or Cabox for a stage for low-risk disease, you will find it the standard, non-inferior. But if you use Folfox for high risk, it is inferior to have to be limited to 6 months. But the use of Folfox 3 months for a stage low risk stage 2, mainly borderline, they did not reach a conclusion, and also if you use Zelox for 3 months. It is very complicated, but we have to reach this conclusion. If the patient is low risk, I mean no N2, no T4, it is better to go for 3 months only, prefer to have Zelox. If the patient is high risk, go for 6 months. Still, the field is evolving. There is a lot of things we will do. I mean, there is sub-classification of the disease according to the marker. I mean, is there any role for the RAS, BRAF, MSI in this subgroup of patient? There is a recent publication showing that, yes, there is difference, but it needs more validation. There is also a role. The role of neoadjuvant and adjuvant chemotherapy will be covered by the next session. So my final take-home message that yes, 6 months of oxaliplatin-based adjuvant chemotherapy is still the standard of care in stage 3 colon cancer, but associated with increased toxicity, mainly peripheral neuritis and diarrhea. Shorter duration of adjuvant treatment, mainly Cabox, I mean 3 months, can be safely given for low-risk patients with significantly lower toxicity. Still, we are waiting the evolving role of circulating tumor DNA and biomarker to assess properly the risk stratification, and we can classify our patient based on this and determine our treatment duration based on this. Thank you for your attention.
Okay. I will go on for questions. Okay, thanks, Dr. Salem, for this very informative. Thanks, Dr. Salem, for this very informative lecture. I think we highlighted 2 main concepts or ideas we have. The first one is the heterogeneity of the disease. Colon cancer is not this one big disease. We have heterogeneity of patients, a lot of pathological characteristics that needs to be considered when we are taking the decision of treatment. And I think the second concept is how we interpret clinical trials. I mean, we have, like in the IDEA trial, yes, we have a statistical significance which should not be, or not that strongly correlated with the clinical yes, significance. I think this area needs more interpretation and more work in our minds before taking decision. My question mainly focusing on the role of oxaliplatin in stage 2 colorectal cancer, when to add it and when to consider it, because in patients, as we have seen in the ESMO guidelines with MSI high tumors, they are adding oxaliplatin in this population. So can we say that the oxaliplatin can overcome the MSI-induced resistance to chemotherapy? This is the first question. And in stage 2 patients, when we are going to consider oxaliplatin-based chemotherapy, what is the optimal duration in these patients? Thank you.
Thank you, Noah. I try to summarize in the talk because you know, and all of you knowing that the field of adjuvant really expanding, and there is a lot of factors. How to use these factors is very complicated, and already there is interaction between these factors, and still we are waiting for some data to be mature to answer the question properly. Up till now, your first question regarding the role of oxaliplatin in stage 2. I mainly found its value in T4 disease and the patient with high risk. If the patient is MSI high but have high risk features, it is better to go for oxaliplatin-based chemotherapy because you know that there is data to show detrimental effect of capecitabine or fluoropyrimidine only agents for this group of patients, and there is at least no benefit from single agent fluoropyrimidine. But if the patient is MSI high low risk, you will not give anything, but high risk feature, you will go for oxaliplatin. The duration, I think for this stage, I will not go for 6 months of treatment. It is, yes, and the idea regarding stage 2, the idea analysis showed still 6 months inferior to 3 months even in stage 2, but I will not go for 6 months for this patient. I will stick to 3 months. I think it is enough even for patient with T4. So T4, MSI high, or any high risk feature may be 2 or more factors, which as the ESMO guidelines, which is I'd like to advise you to follow the ESMO guidelines up till now, till we have the technique of circulating tumor DNA. What's the other question?
Thank you, Professor Salim, for this excellent presentation. I see a lot of junior stuff in the attendees. No. My question is still till now 6 months adjuvant treatment for stage 3 colon cancer is the standard of care.
Yes.
Even Axel Grothi, when he summarized his IDEA trial, he stated that 6 months is the standard of care until now, and 3 months Capox or Xilox is an option only if you are afraid
Yes.
of toxicities. So till now, the low risk stage 3 colon cancer still the standard of care is 6 months, not 3 months.
It is difficult to say that. At subgroup analysis, if you'd like to follow subgroup analysis, I'm always going with 3 months, and if I'm comfortable that this patient is low risk, but I'll strict follow the Capox regimen, not the FOLFOX. The data not conclusive regarding 3 months of FOLFOX, but if I give the Xilox, I can safely go for 3 months. It's subgroup analysis. I totally agree with you. But the other point, there is some data also you can, the problem with the toxicity, as you know, there is some data that you can start 3 months with Capox and you can de-escalate the treatment to another 3 months of single agent capecitabine, and there is a lot of data to confirm this issue. So the problem, mainly the concern of the duration and the concern of toxicity and the cost. So if you feel that your patient, you are not comfortable and you face a toxicity, you can de-escalate to single agent for capecitabine for another 3 months. But it's schools in the management, but for my personal opinion and low risk, I can go for 3 months safely for this group of patients.
Also, my second point is the circulating DNA. Circulating DNA until now is a...
ممكن الباب لأن أنا مش سامع فعلا. أنا مش سامع فعلا للأسف.
Also considering the circulating DNA until now is a prognostic marker, not
Yes.
a predictive. So we can use it as a prognostic marker and for clinical research for decision of treatment. But until now, it is not for prediction or to decide to give or not to give the adjuvant treatment in stage 3.
I couldn't tell it is a prognostic or predictive marker. I can tell it is another way of staging of the disease. In the leukemia patient, we consider the MRD or the minimal residual disease is one of the factors which affect the remission of the disease. The same concept for circulating tumor DNA is MRD in colon cancer. So I consider personally it as one of the staging of molecular staging of the disease. The problem you have, it is not used in the practice because the technique need validation and they couldn't assess its proper usage. You will assess it based on the prognosis. I mean, the patient with positive circulating tumor DNA will have a poor prognosis compared with negative. Yes, they prove this. But on the other side, it can be used as a predictive because patient with positive tumor DNA who receive chemotherapy and clearance of this already have a good survival compared with patient with so you can use it as predictive. So we couldn't fit this category as predictor or prognostic. I can identify this as a minimal residual disease of the disease or molecular staging of the disease. I like this concept because based on this concept, we can decline or de-escalate treatment or escalate treatment, and the field is evolving, but the problem is practicality and the technique is difficult and there is no consensus which technique you will use. So it is molecular staging of the disease or minimal residual disease.
My last question about the daily practice. Do you still use oxaliplatin in stage 3 old age, 70s or even above 65?
There is some concern about patient with 70. Some data show that oxaliplatin in the age above 70, no benefit compared to single agents. But you know it is subgroup analysis. At the end of the day, you and your patient, based on the morphology, the patient already biological age, the stage of the disease. So I have patients with 70 something and already high risk. I will not decline the oxaliplatin for this patient. But on the other side, if a patient, the comorbidity is higher and the survival is low risk, I will not give oxaliplatin. So a lot of other factors. So I will not rely on this data solely for decision making.
Thank you, Professor Salim Ifrag. We'll do some modification in the schedule because we have Professor Mark Peters now online for a virtual lecture. He's going to talk about the current treatment of metastatic colorectal cancer, basic strategies according to molecular subtypes. Sorry, Dr. Farouk. Sorry.
Can you see my slides?
Yes, sure.
Okay. So thank you very much for the invitation. I'm really sorry not being with you, but I try to give my thoughts on the treatment of metastatic disease because this area is also going very fast. I'm going to share my slides. So what we have seen over the years that even with adequate adjuvant therapy and neoadjuvant strategies, at least 15 to 30% of our patients are presenting with metastatic disease. And during the course of the disease, another 50% will develop metastasis at different sites. We also know that depending on the site, the prognosis is different. For example, if you have a patient with brain metastasis, the overall survival is worse than patients with liver or lung metastasis. Looking to the 5 years survival, and these are data from the Belgian Cancer Register, you see that patients with stage 4 have a 5-year survival around 20% for the moment. But you also see that some patients have. Can I move back?
Professor Mark, we are not hearing you well.
Yeah, I'm trying to get my slides back. Okay. So what we see here is the survival, 5-year survival of the patients with unknown.
Professor Peters, we lost the slides. Yeah, please share the screen again.
Wait a minute, I'm going to share it again. Otherwise, can they show my slides? They have my slide deck. I think it's much more easy. Can I get my slides?
Professor Peters,
Yes.
I can share the slides from my side if you want.
Yeah, I think it's better
Okay.
because there is a connection problem. If you show my slides. Okay.
Okay.
So, next slide. Next slide. Okay, so what we see here is, and this is based on the screening program that we have in the Flemish part. If you have a patient with screening detected colorectal cancer, the chance to have metastatic disease is clearly lower than patients that are diagnosed without screening. And also the interval cancer, you see that the chance to have stage 4 disease is much higher than the screening detected colorectal cancer. Next slide. So this is an old slide, but it's still valuable. You see the different options concerning systemic treatment. You have on the left side the chemotherapy. In the middle, you have the older targeted therapy. And on the right side, you see the newer drugs, immune therapy, but also more targeted drugs based on information of the tumor, but also of the metastasis. Next slide. The strategy over the years also clearly changed. We had, in the beginning, 20 years ago, only chemotherapy, and we moved from first to second and third line. Then we had the introduction of targeted therapy, and nowadays we are more aggressive. That's the reason why we are combining systemic treatment with interventions like SIRS or even surgery. At the bottom, and that's the reason of my talk today, is what is the information from the molecular profile and trying to integrate that in our strategy. Next slide. The example, how we moved from all patients treated with a certain targeted therapy towards KRAS and finally a RAS detected population, meaning you decrease the number of patients that can be treated with these drugs from 100% up to 35–40% today. Next. But also the field is changing. You heard some minutes ago from my colleague that circulating tumor DNA can give you more information. What is the impact of your treatment on the clones that are clearly having an influence on the outcome of the patients? And circulating tumor DNA can play a role in that, although, again, in most of the instances, it's still a scientific tool that gives you more information how to integrate, for example, clinical trials in this setting. Next slide. So what is the difference between the liquid biopsy and the tissue? The advantage of liquid biopsy is clearly that it's non-invasive. It gives you some information on tumor heterogeneity. There is rapid turnaround time. And what is important is at the bottom of the slide, there is still a high cost. There is a possibility of false negative, and in certain patients, there is no circulating tumor DNA that is detectable. So there are some problems with liquid biopsy to integrate that in clinical practice today. Next slide. So what are the potential explanations for the difference between plasma and tissue? You have the spatial heterogeneity, for example, RAS/BRAF mutation in tumor tissue versus liquid biopsy. You have the temporal heterogeneity, so that during the treatment you see, and also between metastatic disease and the primary, a difference in the profile, and also the assay sensitivity is still under discussion. Next slide. So this is an example where you see that under pressure of therapy, you have a patient with RAS/BRAF and EGFR wild type. Under pressure of treatment, you see that other subclones are coming up and being important for your strategy. The problem was, and that is next what we're going to discuss, is that most of the mutations that were found at that moment were not targetable, but we clearly moved in that space and we have other options available. Next slide. Can I have, yeah. So this is a profile of a patient where you see under pressure of antiretroviral treatment, you see an impact at the above part of the slide. You see the impact on the target lesions decreasing, but you see that some of the mutations are popping up and influence the sensitivity for the treatment that you give to your patient. The question is, how can we translate that in clinical practice? Next. For that, we have to look for other cancer types. If you look, for example, for breast cancer, there is a clear molecular differentiation between the different histological subtypes, but also in the space of lung cancer, there is a lot of information on the different mutations and the different molecular factors that are influencing the outcome, and also the link with therapy. Next slide. What is the situation in the colorectal cancer biomarker determination? So what are the tests that are potentially important for patients in 2023? First of all, of course, RAS is still an important biomarker, but you see on the right side and in the middle that different markers are important to give an idea of what is the target therapy that we want to give to our patient and what are the combinations that are possible. Not only RAS, but also BRAF, PIK3CA, MSI, ERB fusions might be important to guide your decision, not only for the classical therapy, but also for clinical trials. Next. So currently, for me, the most important message is that we need a multidisciplinary molecular tumor board for patients with metastatic disease. It's not that we are deciding based on guidelines. It's an open discussion, and you need all that information to have the exact management for the individual patient. Next slide. For example, if you have a patient with a BRAF mutation, it's important to see what are the options and where the targets can be hit by the drugs that we have available. Next slide. And that was shown by the study published in the New England, which is currently in most of the countries routine, where you are using either a doublet with an anti-TVR or a triplet therapy to control the disease and to have an impact on the overall survival. Next slide. HER2 is another target which was known from breast cancer, but also played a role in colon cancer. Different testing methods are available. What is also important that the clinical presentation is different from the classical ones. You see that more distal colorectal cancer are diagnosed, and there is a greater incidence of brain metastasis. It's also important, recent data showed a relationship between HER2 mutations and MSI stages. Next slide. Several trials are, for the moment, under investigation. There are some that are already reported at congresses and also in publications. You see on the right side that it's not only the HER2 stadium that is important, but also the combination with, for example, amplification. The combination with RAS-BRAF might influence the strategy in your individual patient. Next slide. We have all seen this data phase 2 study in HER2 amplified metastatic colorectal cancer, where high responses were detected in heavily pretreated patients. One of the problems with this drug is the side effects, where interstitial lung disease might have an impact on the outcome and may be fatal in some of the patients. So it's a question of fine-tuning, but again, we modified our strategy in these patients based on the information of the biomarker status of the tumor. Next slide. We already mentioned that under pressure of a given treatment and based on the information of the circulating tumor DNA, a patient with a RAS wild-type tumor might have other mutations than the classical ones. And the question is, can we target these tumors with newer drugs? Next. And the answer is clearly yes. We have seen some data on the KRAS G12C inhibitors. It's only a fraction of the patient, 3% of the colorectal cancer patients, but also other targets, for example, G12D might be important in the future. We have a lot of drugs that are under investigation, but for example, for G12C, already drugs are available and approved in some of the countries. So if you look back 5 years ago, these were tumors that were not druggable, but with the new information, with the new drugs available, this gives another option for patients. Next. G12D, more frequent than G12C, not only in colorectal cancer, but also, for example, in pancreatic cancer. And you see on the right side, based on some xenograft tumor models, that these new drugs are interesting and might have an important impact on the clinical situation of our patients with this specific mutation in the future. Next slide. One of the problems is also the fact that patients with MSI-high tumors, some of these patients are not responding to the classical immunotherapy. Also, their work has been done to more precisely indicate which are the patients that are sensitive for immunotherapy and which are resistant or become resistant. And for example, at the bottom of this slide, you see that patient with MSI metastatic colorectal cancer and a lower TMB value have a worse outcome than the patients with a higher TMB. And this information might impact the use of immunotherapy, the classical ones. Next slide. But also we have to look in that field for newer strategies, not only the anti-PD-L1 or the anti-PD-L1 antibodies, but also, for example, there is a possibility that vaccines are becoming much more important, not only the personalized vaccines, but also the agnostic vaccines. And this might be in combination with the classical checkpoint inhibitors that we currently know. So there is still an unmet need, but not only companies, but also academic centers are investing a lot of scientific knowledge to overcome the problem of immunotherapy resistance in our patients with colorectal cancer. Next slide. What about the MSS, metastatic colorectal cancer? We know that it's a challenge for the moment. There are not a lot of options for these patients with immunotherapy, but it's clear that also here you need to differentiate based on the CMS classification, different subgroups, and it might be that even what we currently know as cold tumors might be targetable by the new combination with immunotherapy, either in combination with chemotherapy or in the future with tumor vaccines. Next. So these are my last slides. So the question is, how can we move further? First of all, we have, like I said, different other biomarkers that we are trying to integrate in our daily strategy. A second is also the fact that we have more and more drugs available and combinations that we can use in the future. You have the area of the tumor vaccines, but also the fact that small tumor samples can be grown in vitro organoids, and this might change the strategy in the future. That means that you have small tissue, we make organoids, and we are testing the sensitivity of the tumor for the drugs that we have available in a given patient. Next. So the question is, is this for the future? I'm convinced that based on the results that we have, based on the fact that we can grow these type of tumors very easily for the moment, I don't think it's a far future, but probably it's in the next years that we will see some interesting results to test our individual tumors on the sensitivity for the drugs based on the biomarker information that we also get from the organoids. So for us, organoids is not something that is far away, but probably the next step in personalized medicine, and especially in GI tumors and metastatic colorectal cancer. I thank you very much, and I'm open for questions.
Thank you, Professor Peters, for this elegant presentation. Any question from the floor?
Thank you, Professor Peters, for your excellent lecture, actually. And my question is about the use of the triplets in your practice. Do you use the triplets or not? And if you do it in patient with wild-type disease?
It's a double answer that I want to give. First of all, is the triplet the standard? No. We have seen recent data where they compared the doublet with triplet in combination with one of the antibodies that we have available, and we have seen interesting data that even the doublet is working very well. For example, the recent study, the Cairo 5 that was presented at ESMO, showed clearly that the doublet is probably even as good than the triplet. Second, in some patients where you want to obtain high response, rapid response, probably in that patient population, the triplet is still a very good option. And the third point is you need to balance the advantage versus the side effects, and especially in frail patients, sometimes it's not easy to use the triplet. And the last point is, if we want to use the triplet, I would use a modified version, because there we know that the toxicity is much better than the initial triplet that was described. So it's, again, an individual decision, but it's not the standard in every patient that we are using the triplet currently.
So continuing on this question also, Professor Peter, what your opinion regarding yes intensified by triplet in patient with liver-only metastasis? There is some concern about the benefit of triplet in those patients, even if left-sided. I know there is benefit in right side, but in left side with liver-only or liver-limited metastasis.
Yeah, I think I already mentioned the Cairo 5 study, which was a very good conducted Dutch study, where patients with initially unresectable liver metastasis were treated in different arms, not only the arm with the mutant, the RAS mutant population, but also the wild type population. And what was shown there was clearly the answer that you want to have is that even the doublet, for example, in combination with bevacizumab, or the doublet in combination with panitumumab for the RAS wild type population, was showing the same result than the triplet. So also that study specifically looking for liver only, not resectable, trying to get the patient to resectable disease, showed that the doublet is probably a good option even in that specific population.
Thank you, Professor Peters, for your talk. Now I will introduce my dear colleague, Professor Mohammed Farouk. Professor Mohammed is a professor of clinical oncology at Alexandria University. He will present a talk about the new adjuvant immunotherapy for localized CRC, facts and future perspectives.
بسم الله الرحمن الرحيم. طبعا ألف مبروك على المؤتمر الجميل ده، وبالتوفيق دايما باستمرار، وإن شاء الله دايما من أحسن لأحسن ومن تقدم لتقدم. I have to thank the organizing committee for giving me the chance to be with you today, and my talk will be about neoadjuvant immunotherapy in localized colon cancer. I'm not going to make it long one. It is a short one actually, in 15 minutes. And the story started once we asked the question about the role of neoadjuvant chemotherapy in colon cancer. This was a question a few years ago. Why? Because we have some data about that our patients started the chemotherapy 2 to 4 months after the initial presentation, and this is considered the time for the micrometastasis to develop. And another important point that we have some important examples of success of the neoadjuvant in the different malignancies, including the GIT, whether we are talking about the gastroesophageal junction or rectal cancer. And the third one, that if we used the oxaliplatin-based chemotherapy for 6 weeks before surgery, the incidence of progression is less than 5%. And hence came 3 important trials. One phase 2 trial, PRODIGE 22, and 2 important phase 3 trial. Chinese one, the optical, but the most important, the largest one was, of course, the Foxtrot. The Foxtrot trial compared patients' surgery, 24 weeks of adjuvant oxaliplatin and fluoropyrimidines versus only picking up 6 weeks of chemotherapy to put it before surgery, and then do surgery and continue the 18 weeks of chemotherapy. And with that, you can find that there was improvement in the incidence of the recurrence rate, to the degree that you can see in this slide that the absolute gain in the neoadjuvant setting in the disease-free survival is 5.3%, which is comparable to the value of adding oxaliplatin to fluoropyrimidine in the adjuvant setting. You can imagine how much just by taking 6 weeks of treatment before surgery you can gain, or your patient can gain. And by going in details into depth of this trial, we find that patients with pMMR or proficient disease who are the only winners. The pathologic response rate was nearly 20% versus 5% only in patients who are having dMMR. And this is very important. Patients with dMMR are considered another population. This population depends on what's called the neoantigen. Even the evolution of cancer of this patient and the treatment depend on the presence of the neoadjuvant. As you can see here, that this is the pointer, yes. We have mutations here occur in the DNA. These mutations will go here in the protein, so it is mutated proteins. Proteosomes will act upon these mutated proteins to produce the neoantigens. The neoantigens will be represented to the T cells through the major histocompatibility system, and this will lead to evolution of the immune cycle or immune response. And what is important also in this category is not the high TMP, but the quality of the TMP. So both the percentage of the TMP, of course, above 10%, and the quality of the TMP, both of them will determine the very foreign immune peptidomes, which will lead to high response rate to immune checkpoint inhibitors. Actually, we have several immune checkpoint inhibitors that had been tested in the second line, in the third line, and even in the first line, and all of them gave us the same story. From 30 to 50% response rate, improvement in the progression-free survival, and plateauing of the curve, which is very important. The best example will be here from the Keynote 177. We know that Pembro, when added to these patients, you can see that there was doubling of the progression-free survival, and that in those 40% of the patients, there was nearly a sort of plateauing up till you can see here 60 months. 60 months, and still there is plateauing of the curve. That means that these patients may be cured from their disease. What about transferring this data into the neoadjuvant setting? We took it from the melanoma actually. As you can see here from this slide, that if we started the immunotherapy before surgery, like here, we have activation of many T cells. And these T cells subtypes will be present there after surgery, searching for the small micrometastasis, trying to eradicate it. And you can see the difference in survival in the curves between those who started neoadjuvant treatment in melanoma and those who received adjuvant only, okay? The first trial in patient with localized colon cancer came from Netherlands, from Miriam Shalapi, and we know the NICHE study. The NICHE study included 35 patients, or 30 patients DMMR and 30 patients PMMR, and they received only 2 cycles of immunotherapy. The first one was the Nivo-Epi, and the second one was Nivo, and after that, by 2 weeks, all of them underwent surgery. All patients underwent surgery. There was no any problem to do surgery for these patients. And look at the pathologic response for the DMMR cohort. 100% of the patient had response, including 60% complete response for this group of patients. This had been confirmed by the larger trial, the NICHE-2, and the NICHE-2 included 110 patients. These patients also received the same story, 2 cycles, the first one Nivo-Epi and second one Nivo, and after that, by 2 weeks, there was surgery. And you can see here that these were very locally advanced diseases. You can see high-risk patient in 70-something%. T4A and B constituted 70% of the patients. Look at the type of the tumor they were treating. They were treating very large tumors, locally advanced tumors attached to the nearby organs, and 98% of the patients underwent surgery, meeting the safety primary endpoint. And here is the major pathologic response, which was seen in 95% of the patients, including 67% complete pathologic response. And here is the data of both NICHE-1 and NICHE-2. You can see it very clearly in front of you. And this is very important, that with a median follow-up of 13 شهر or 1 year, there have been no disease recurrence. So no disease recurrence with a median follow-up of 1 year, and we are eager waiting for the results, the 3 years disease-free survival, which will be presented next year, inshallah. Another data came from CERSEC in rectal cancer. We are all familiar with this data from the rectal cancer. 12 patients treated with dostarlimab, and all of them got complete clinical response. And after 6 months of follow-up, they were in the clinical complete response. And I don't know if any update for this trial had happened in the last few months. A third data from the neoadjuvant Pembro trial. And again, you can see that the complete pathologic data here is approaching 70%, as you can see. And the most recent data that had been published in the last ESMO a couple of weeks ago is the NICHE-3. And in the NICHE-3, they were evaluating actually Nivo in addition to relatlimab. Why relatlimab Nivo? Because this combination was safe in melanoma, actually. And thus, you can see again, 2 injections of Nivo relatlimab, one 8 weeks before surgery, the second one 4 weeks before surgery, and you can see the primary endpoint was the pathologic complete response. These are the patient characteristics, and again, 100% pathologic response, including 80% complete pathologic response and 90% major pathologic response. Of course, there was a 24% of the patients developed endocrinopathy that required supplement. And the conclusion of this data, or the NICHE-3, neoadjuvant Nivo relatlimab achieved a 100 pathologic response rate, including 80% complete pathologic response. Grade 3 immune-related adverse events affected 5% only. No surgical delay. We are waiting for part 2, which will be again presented after 1 year. By that time, I finished actually the data about the neoadjuvant immunotherapy in colon cancer, but 2 important points. We have to pick up those with polymutation. Polymutation is a group of patients who are having hypermutated disease. They are present in less than 1%, but they are responding very well to immunotherapy. We have to put them in our consideration, of course, if we have resources that allowed us to do so. And one last point is the MSS patients. What about MSS patient in the metastatic setting? Is there any rule for immunotherapy in these patients? Actually, don't depend on the TMP in these patients, because the quality of the mutations is not high. This is important. We have 3 ways trying to improve our use of checkpoint inhibitors in these patients: to combine them with chemotherapy, to combine them with anti-CTLA-4, or to combine them with the TKIs. Data about TKIs, as you can see, are evolving. The most recent one is the LEAP-17 trial. The data of this LEAP-17 has been published this year. It is considered negative trial. Pembro, in addition to lenvatinib, was not superior to the standard of care regorafenib or trifluorouridine. But look at here, you can see that patient without liver metastasis, the hazard ratio was 0.4. It seems to be that there is a signal for those who are MSS patients, but without liver metastasis, they may respond to immunotherapy. Another data came from the old niche. It included 30 patients with pMMR, and these patients had a 29% response rate. Who are these patients who responded? Patient with high CD8 to PD-L1 ratio, they were the one who responded. So we have 2 points: patients who have no liver metastasis, patients who are having high CD8 to PD-L1 data. Another data from the anti-PD-L1 to the anti-CTLA-4 with the use of new generations of these drugs, botensilimab and palestilimab. The response rate is 24%. And as you can see here, the response rate, 11 out of 16 patients had a response that responded nearly 70% in patients who are not having liver metastasis. Again, so we have data from 2 different trials that patients without liver metastasis may have a signal to be treated with immunotherapy. The last one is the use of chemo in addition to immunotherapy, and we have in this context the ATEZO-TRIBE trial showing that there was no significant improvement with the addition of atezo to the folfoxiri and peva. But again, when they did the immune score in the last data for this patient last year, they showed that those who are having high immune score again and again, the CD8 positive in relation to the PD-L1 was having the best response, and they had a very good hazard ratio of treatment. My conclusion is that immunotherapy is the standard of care for metastatic MSI and polyhypermutated subtypes. Is neoadjuvant immunotherapy the standard of care? No, it is not up till now, but we have very good data evolving about that. It will be very nice to concentrate on the organ preservation like rectal cancer, and thank you for your time.
Thank you, Professor Farouk, for this nice presentation. And the floor is open for discussion. So thank you, Professor Farouk, and by this we end this session. Sorry, Dr. Farouk. Doctor, now I'll ask you a question.
Thanks again for this very nice talk. I think, how do we explain this improved response rates and very high response rates with immunotherapy in neoadjuvant setting in the GIT tumors? Do you consider it is going to be really the next common standard of care? And do we have currently data on the adjuvant use of immunotherapy in colorectal cancers, and how
To my knowledge,
explain
excellent.
this.
طبعا أسئلة نوع كلها جميلة. Excellent question. To my knowledge, I don't have any data about the adjuvant. But do you think that it will be something in the future for neoadjuvant? I think yes. But it needs standardization. It needs randomized trials. It needs يعني ما يبقاش إن هي جهود حد واحد أو investigator واحد في حتة واحدة. الداتا evolving جامد جدا في الحتة دي. I think إن محتاجة ميتا أناليسيس ومحتاجة داتا تخش على randomized trial. I think ساعتها هيبان إن بس هنعمل بقى خطوط إمتى هندي قد إيه. إحنا بنتكلم في ناس بتدي 6 شهور، في ناس بتدي 2 cycles only، في ناس بتدي أكتر من كده. هنحط نعمل ايفالويشن للجراحه امتى، هنعمل ايه البيست واي تو ايفالويت الكونديشن دلوقتي بسي تي ولا بيت سي تي ولا ايه. اي ثينك محتاجه لسه يعني المزيد من الفيز 2 فيز يعني مالتيبل فيز 2 ستاديز، وبعد كده تتجمع في فيز 3 ستادي هتبقى هتدينا داتا كويسه جدا. But I think it is the future, and I think that we are going to take some patient with اللي هو micro satellite stable. They will pick up this group of patients اللي بيمثل حوالي من 20 ل 30%, and these patients are going to be turned into hot disease إن شاء الله. Thank you, Dr. Thank you.